Hello, I'm Dr. Amar Chan from World Medicine Hub, and today I'm going to discuss a very important topic which is not discussed in India, and that topic is how not to resuscitate. So this sounds a little bit erratic because we have been taught, we have been bombarded how to resuscitate the patient. We know that, but sometimes because why I'm discussing this topic, I have got a couple of patients. I rather got their summary also, and there I found that the care they received, the resuscitation they received was suboptimal, and it really terrified me, and I thought I must discuss it with you people so that next time you resuscitate a patient, please don't do these things which I'm going to discuss. So these are not imaginary cases, these are real cases. I got on WhatsApp, and I think one or two patients came to me also. So the first patient is an 18-year-old boy who met with an abdominal trauma. He is taken to a local hospital where he is kept around 1.5 hours, and then as they did not have the facility, they referred him to a corporate hospital. Now when this boy arrives at the corporate hospital, he is tachycardic, he is diaphoretic, although he is maintaining his blood pressure, but we know that this patient is sympathetic all right. So E-fast is done, and that is positive. After that, they are waiting for him to go to scanner, and that's where this patient collapsed. He became hypotensive, and then instead of starting blood or blood product, he is started on vasopressor, noradrenaline. And this is the summary I have with me. Although it's not clear, I don't want to show it, it's blurred. So, and then still the CT scan is done. He is not taken to OR. And after the CT scan report, he is taken to OR, and the surgeon who is doing the surgery is not a trauma surgeon, right? So that's another problem in India. We tend to behave all general purpose specialists, which is not the case, right? You need to have domain specific knowledge. Like with such a severe trauma with multiple organ injury, I'll discuss subsequently the type of injury this boy suffered. The injury really caused havoc in his abdomen. So he operated this patient, and he doesn't have any idea what to do, because as he opens up the abdomen, what he gets, although it is there in the CT scan, he has got complete division of the pancreas, he has got an IVC injury, he has got a renal vein injury, he has got I think mesenteric injury leading to some gangrene, and then he started calling one after the other surgeons. So this is absolutely not acceptable. When you have a patient who has got so many injuries on the CT scan, you must go with a team approach. And then what he does further, that he closes his abdomen. We know that in such patients, when there are so many injuries, patient is unstable, what we need to do is damage control surgery, which is clearly not done in this case. And somehow somebody WhatsApp me his summary, and I shared this summary in an international trauma group, and everybody was the opinion that this patient was suboptimal care. Instead of closing his abdomen, and obviously he suffered then stitch abscess and sepsis, he could have undergone a damage control surgery. So then the boy was very poor. He was the only son of the family. His father was a laborer. They could not afford the expenses of this hospital. So they went to a government trauma facility where the boys come to his injury. This is very sad, very sad, difficult to understand. So this boy who has got blunt abdominal trauma, E-fast positive, should go to OR. Any time in a trauma patient, fluid in the abdominal cavity or in the pericardial should go to OR, because these patients are very unstable. They have very unpredictable course. They can collapse anytime. In chest trauma, there is a fluid, we can put a chest tube and can observe the patient. But in case of cardiac trauma, pericardial effusion or tamponade or abdominal trauma, we must take the patient to OR and do urgent laparotomy. So that was the first case. Now the second case is another hospital, another story. It's also a very saddening story. This is the patient who present to the ER as per their notes in the gasping condition. And then there he collapses. he become unresponsive. That's what they have written. And instead of starting CPR immediately, they are assessing ABCDs. I don't understand from where they got this idea. So they start assessing ABCD, and then they start CPR. Then they are in hurry in intubating the patient, and then the drugs he gets is absolutely a cocktail. He gets every medicine which is there in the ER. He gets adrenaline after ROSC, he gets noradrenaline, he gets sotabacal, he gets calcium, he gets Tantrop, MSAT, a lot of things going on which are not required for this patient. And after intubation, he on 2 drip, adrenaline and noradrenaline. He is transferred to some other hospital. Again, the affordability is the issue. But when I went through the summary, it really horrified me. I was taken aback because, let me tell you, when patient is unresponsive, then you don't go for ABCD assessment. You immediately start CPR. And then intubation is not our priority when we are resuscitating patient of cardiac arrest. Okay, BVM is good enough, IGL is good enough. Okay, and then a beating heart should never get an adrenaline. That's the principle. And here we have patient who is on adrenaline and noradrenaline. So this is the type of patient they should not be treated in such a manner, and this is very worrisome. And these things are happening day in and day out in India. And when I discuss these things in group, nobody comes forward, they don't give their opinion. That is why there is no improvisation, there is no betterment taking place in emergency medicine. We need to speak out. Okay, now the third patient is again, this is a patient of again road traffic accident, and she get head injury. She goes to some hospital. There it is documented her GCS is 7 or 8, but the patient, and she doesn't protect her airway, doesn't have a intact cough reflex, and the patient is kept in the hospital for 1.5 days without any definite airway support. Result, she suffered further hypoxic brain injury, and then she is taken to government facility, and she also succumbed to her injury. Because there is no way. We need to prevent hypoxia, hypotension, hypothermia, and the acidosis in trauma patient, which was not done for this patient. And she was a young lady, 25-year-old with a baby, and she died. She died in a very tragic death. So these are the cases which really force you to think what is going on and how we can make things better. Now coming to my last patient, this is again, this patient after multiple gunshot injuries, he goes to a corporate hospital. The doctor who accompanied this patient told me then when this patient arrived in the corporate hospital, and this corporate hospital is run by a renowned international cardiologist. And the sad story is that they start doing CPR. The paramedic was there, the doctor was there, he told them this is a patient with gunshot injury, and they are doing CPR. Again, this is a blunder, this is a monumental mistake. In gunshot injury, the problem is pericardial tamponade, or it is like the bleeding to death. So we need to fill the heart rather than doing CPR. And again, they were told that he has got pericardial effusion because this patient was seen in some other hospital. There they started blood, they did the ultrasound, and the research thoracotomy was not done, emergency thoracotomy was not done, and then this patient also stopped. So these are the cases which I came across, and I feel concerned that being in emergency care for the last 25 years or so, and in acute trauma care, I have seen such patients, and we do swift action. So now what we can learn from these cases. So my request is, my humble submission is that whenever you have any sick patient, please ask these 4 questions. Right, what you are dealing with, that's number 1. Are you understanding what the patient is? Then what are your priorities? Set your priorities in a very distinct manner. Then if you are not capable, then please call for help. If you are not capable, please call for help. Don't delay help in very sick patient, whether it's a trauma or non-trauma. Ask this question, and then if you start treating the patient, if the patient's condition according to your diagnosis is getting better with your treatment, if not, then please reiterate. You must have fast data processing in your mind. Like if this is not fitting with this patient, if patient is not improving, or the lab investigation is not going with the patient's condition, please change your plan. You have to be very fast, right? Then only you will be able to hit the nail on its head, and you will be able to save the patient. So my request is always, again I would emphasize, I will say it again, that whenever you deal with a sick patient, please ask what you are dealing. You ask yourself, you put some self-reflective question to you. Okay, what I am dealing with, what are my priorities, am I capable of taking care of this patient? If not, then when to call, whom to call. These four things you must have in your mind. Keep asking continuously, and if you start treatment, then keep asking your question, is the diagnosis or the hypothesis, working hypothesis, when the patient came, you had in your mind that this is the problem I am dealing with, and if that is not getting better and it is not fitting in your diagnostic armamentarium, then please change your way, change your pattern, change your I would say the treatment strategy. And those who are not expert, please follow the algorithm, please follow the protocol if you are not expert. That is why the protocol, algorithm, guidelines are there. At least you will do the minimum what is required for the patient. You will not go haywire, you will not mess up the things, you will not do this crappy resuscitation which these four patients have received. And I hope this lecture, which is I have titled How Not to Resuscitate, will have some effect and will force us to better and to improvise our emergency and trauma care or resuscitation. Thank you.